Roberto. I hope I'm not boring you too much. But what I will do now is, as you know, we usually have 4 to 5 new guidelines every year, or revised guidelines. And this year, one of them was the new version of the infectious endocarditis guidelines. These are my general disclosures. That were presented in London. And just to give you a little bit of the main reasons for the update of these guidelines, the previous one already had some years, was the role of the endocarditis team, which has been highlighted in these guidelines. Actually, the team word seems to be one of the key words now in cardiology practice. The use of multimodality imaging, there have been some new data, new evidence that has been included in the guidelines. Also, I would say some improvement in the algorithms for diagnosing infectious endocarditis. The antibiotic prophylaxis was unchanged, and we do appreciate that there has been a lot of controversy, particularly in some parts of the world, where some diseases that we don't see as often in Europe, like rheumatic heart disease, there have been some discussions, and I've been in different parts of the world where this has been one point of discussion. And then, finally, the emphasis on the 3 E's: early diagnosis, early therapy, early surgery. And I presented this morning one of the studies that was presented also in London, clearly demonstrated that, particularly in the acute endocarditis, the early surgery seems to be very relevant and improving patient outcome. So these are the main reasons for the update of the guidelines. So let's talk about prevention. We know that the restriction of antibiotic prophylaxis based on risk-benefit analysis came from some data in the early 2000s. So the ESC guidelines restricted antibiotic prophylaxis basically to the patients at the highest risk. And this has to do with many different reasons, but basically from the previous guidelines, which is kept in these guidelines, the antibiotic prophylaxis is restricted to these patients, and I will in a minute just give you the definition of highest risk. And then the NICE, which is, as you know, the entity in the UK, went further to a total ban in 2008, but no new convincing data that incidence has changed since this ban, and the worst prognosis of infectious endocarditis in high-risk patients, like prosthetic valves, the reason why it was kept the same level of prophylaxis in this patient population, and a relatively small number of patients at high risk. So the committee of the 2015 guidelines basically decided to maintain the principle of antibiotic prophylaxis only for the high-risk patients. And again, this is subject to some discussion, but that's what was decided. So the recommendations for antibiotic prophylaxis, and these are the so-called highest risk patients for infectious endocarditis, are patients with any prosthetic valve, including the ones who undergo TAVI, or those in whom any prosthetic material was used for cardiac valve repair, the rings and any prosthetic material. So these are still considered as high risk, and these are the ones where antibiotic prophylaxis is still recommended. Then the second group of patients are the patients who had a previous episode of infectious endocarditis. That's also logical. And finally, the patients with congenital heart disease, any type of cyanotic congenital heart disease, or any type of congenital heart disease that was repaired with a prosthetic material, whether this was placed either surgically or percutaneous, up to 6 months after the procedure, or lifelong if there is a residual shunt or valvular regurgitation remaining. So these are the 3 types of patients where the current recommendations of the ESC for full antibiotic prophylaxis. Otherwise, all other forms of valvular or congenital heart disease are considered as no indication according with these guidelines. Now, a very important aspect, there is a big emphasis on advice for dental hygiene in the patients who are at the highest risk, because we do know this is a big problem even in patients who do take antibiotic prophylaxis. I'm sure you have the same experience. We do see still some patients who develop endocarditis despite taking some antibiotic prophylaxis. So here there are some measures, non-specific prevention measures, that should be followed up in the high-risk patients. So it's not only to do the antibiotic prophylaxis, but also there are some specific aspects and some recommendations that are very clearly stated in the guidelines. And one of them is to do with the dental and the cutaneous hygiene, disinfection of wounds, very careful with any sort of material that is introduced in these patients, things like discouraging piercing and tattooing. We've seen some patients developing endocarditis after doing some of these things, and again, to limit the use of infusion catheters and invasive procedures whenever possible. And of course, also a recommendation, if the patient has a central catheter, there should be a replacement of this catheter every 3 to 4 days to avoid any infection complications. One important aspect to recommend the patients, no self-medication with antibiotics, because we know this increases the resistance for some of the agents that are responsible for endocarditis. Now, the second thing is the so-called Endocarditis Team, and the concept here is the fact that indeed we are not dealing with a single disease. There are multiple presentations. It can be a systemic disease with multiple organs involved. There can be even more than one microorganism involved in the process, multiple symptoms. So there is a need for a high level of expertise, and therefore the recommendation of a multidisciplinary team, again, something that we are seeing more and more. The more complex the patients we treat, the more need for multidisciplinary approach, so involving cardiologists, surgeons, infectious diseases specialists, microbiologists, neurologists, rheumatologists, imaging doctors, and so on. So one important point, and I think this is very, very crucial, and who works in tertiary centers, I think this is very relevant, is to engage the surgeons very, very early, even if the patient has no clear indication at an early stage. It's very important that the surgical team is engaged, is involved, knows about the patient, because data shows that about 50% of these patients at some point in their process in their disease process will need surgery. Therefore, the concept of the endocarditis center to deal with these complex, more complex patients. Now, one of the questions is when to refer a patient who has infectious endocarditis to this endocarditis team. And again, all the patients who have complicated infectious endocarditis, patients who develop heart failure, who develop abscesses, or who develop embolic or neurological complications, these patients should be referred to these centers. Or patients who have non-complicated infectious endocarditis, they can be initially managed in a non-reference center, but there should be a regular communication with a reference center, so in case there is a need to transfer the patient, there is already some knowledge about what's going on. And really, these are, as we know, sometimes very sick patients and patients who may actually have a very complicated development of their disease. Now, it's a big challenge, the diagnosis of endocarditis, as we know. First of all, and probably one of the key things, is to have a high level of clinical suspicion, particularly when the patient has known cardiac disease, if there is unexplained fever, or if just the patient feels unwell. And we have this clinical feeling that the patient is not doing well, and endocarditis should be, it's a little bit like pulmonary embolism. It should be kept in the back of our mind when we have some patients who are not doing well. Keep in mind that endocarditis can be the diagnosis. Now, the classic triad in terms of signs of infection, signs of embolism, and some of these signs, classical signs actually, are immunological, and then signs of cardiac disorder. I will not go into the details, but basically these three different signs of either an infection, either embolism or cardiac disorder will raise the suspicion also of endocarditis. And then we have the big role of imaging, which is becoming really central in the diagnosis of infectious endocarditis. So if you look at the algorithm, you can see that transthoracic echo is recommended as a first-line imaging in all patients with suspected infectious endocarditis, and particularly the ones who have a non-diagnostic transthoracic echo. If there is clinical suspicion, these patients should undergo transesophageal echo. And here I would like to say that in my center, that's very clear. The threshold to do transesophageal echo in a patient who has a suspicion of infectious endocarditis is very low. And particularly for the patients who have prosthetic valves, these patients have clear indication to undergo transesophageal echo, even if the transthoracic echo does not seem to show anything in particular, because we know, particularly if there is a prosthetic valve in mitral position, if it's a mechanical valve, how important it is to look at the atrial side of the valve, because sometimes we do have some surprises. So transesophageal echo in the setting of a prosthetic valve, it's a formal indication to be performed. Now, in all patients who have staph endocarditis, all these patients, regardless of their clinical presentation, is now a two-way indication, because we know also how damaged the sequence of endocarditis can happen in these patients. And finally, it should be considered basically in all the patients who have positive transthoracic echo, the use of transesophageal echo, maybe in the isolated right-sided native valve, if there is a good quality transthoracic echo, and unequivocal echo findings, this may be the only exclusion. But again, the message is the threshold should be very low. If you have any suspicion, do a transesophageal echo, because it can provide you the diagnosis. Now, major diagnostic criteria, these are still the same. So the presence of vegetation, here you have a 3D echo where you can see nicely on the aortic valve. It's a very nice presence of, very nice, not very nice for the patient, but a very beautiful image of a big vegetation. But not only the vegetation, there is also an abscess that you can see nicely here. So the presence of vegetations, abscesses, or pseudoaneurysms, or new dehiscence if there is a prosthetic valve, these are also major diagnostic criteria for endocarditis. Now, it's included now in the guidelines, the new imaging, some of the new imaging modalities based on some new data and new reports. So multi-slice CT may be useful to diagnose abscesses, pseudoaneurysms, perivalvular extension, fistulae and concomitant pulmonary disease. Magnetic resonance in CMR can be particularly useful if there is any suspicion of cerebral lesions, mycotic aneurysms, or any suspicion of embolic phenomenon. And nuclear imaging, particularly the use of PET, to look at some inflammatory changes that can actually be useful to detect, not only for the diagnosis of endocarditis, but also the source of infection. It can be useful, and there are quite interesting case reports demonstrating the use of PET to show the presence of inflammatory areas in some parts of the body that may be responsible for the endocarditis. So that's why now in the new guidelines it's incorporated some upgrade, I would say, from the classical Duke classification of infectious endocarditis. So now on top of the positive blood cultures, which of course is one of the major criteria, the second one, and is reinforced now, it was present already in the previous Duke, but now is reinforced, the imaging positive for infectious endocarditis, echo, but also it's now, you see in B, the abnormal activity around the site of a prosthetic valve implantation, for instance, detected by PET, and also definite perivalvular lesions by cardiac CT. These have been included now in the guidelines. And the other thing regards the presence of, in the minor criteria, of vascular phenomenon, including those detected by imaging only. This is also a new addition in these guidelines. And now it is the diagnostic criteria is divided in three parts. So it's either a definite diagnosis, a possible diagnosis, or a rejected diagnosis. So it's definite diagnosis if there is two major, or one major and three minor, or five minor, any combination. Possible if there is at least one major, plus one minor or three minor, and rejected if there is a firm alternative, if there is symptom resolution, or if there is no pathological evidence of any form of infectious endocarditis. Now, here we have basically defined in the algorithm this classification and this diagnostic algorithm. So clinical suspicion, modified Duke criteria, the definition of the three different types. So if it's definite, the diagnosis is done. If it's rejected, it's rejected. It's, as always, in the middle, in the possible, that we have to be very aggressive in the way we go looking for the source of endocarditis. And in this case, we will be very aggressive on the use of imaging. And then once we use the imaging to make sure that we looked at everything possible to exclude endocarditis, then we reach our decision. Is this a definite endocarditis? It's still possible, or we can reject the diagnosis. Now, what are the predictors of poor outcome? We know that there are some patient characteristics like older age, presence of a prosthetic valve, diabetes or other comorbidities that can be, if present, they represent poor outcome for the individual patient. The presence of clinical complications of the infectious endocarditis, if the patient develops heart failure, renal failure, if there is more than moderate area of ischemic stroke, brain hemorrhage or septic shock, these are very ominous signs of poor outcome. The type of the microorganism, the Staph aureus endocarditis, those are terrible endocarditis as we know, if they are fungi endocarditis, and also the gram-negative bacilli that can be also responsible for very destructive type of endocarditis. And then some echo findings which can actually, if present, represent poor outcome. If there are periannular complications, severe left side valve regurgitation, if there is impairment secondary of the disease on left ventricular ejection fraction, if there is development of pulmonary hypertension, big vegetations, severe prosthetic valve dysfunction, or premature mitral valve closure, or other signs of elevated diastolic pressure, which means that there is already some important hemodynamic implications of the disease process, and these are all predictors of poor outcome, and these are actually, when present, a reason to refer this patient to the reference center, as I've mentioned before. A final word on the indications for surgery, again, is one of the E's, early surgery, so the surgical team should be involved as early as possible, but the indications can be divided in three main areas. So one, when the patient develops heart failure, or if there is uncontrolled infection, or to prevent embolism, which is basically based on the location, the size of the vegetations. For instance, if there are persistent vegetations more than 10 millimeters in the aortic or the mitral, either native or prosthetic valve, after one or more embolism episode, despite appropriate antibiotic therapy, is now a 1B indication clear for surgery, and some of the other, the presence of some of the other instances are also now clear indications for referring the patient for early surgery. And again, as I've shown today, if the patient develops one of these complications, this is an early indication for the patient to undergo surgery. We do know and we do understand the surgeons, this is a very bad area to be treating and to be suing and so on, but it's also very important to understand that if we do nothing to these patients, and if they already develop these very complex complications, the patient basically will die anyway. So this again is early consultation with the cardiac surgeons. Finally, for the right-sided infective endocarditis, which we know it's a little bit less frequent, we do see it still with some IV drug users or some immuno-incompetent patients. But in this case, the surgical treatment should be considered if there is a microorganism which is difficult to eradicate, for instance, fungi. They are more common on the right side. If in the tricuspid valve, the vegetations are bigger than 20 millimeters, and particularly if there is recurrent evidence of pulmonary embolism, and finally, if there is evidence of right heart failure secondary to severe tricuspid regurgitation, it's a two-way, so it means it should be considered surgery in this patient population. So with this, I will finish. This was just an update on some of the new features of these guidelines on an important feature of, or an important disease process, very complex, but very important to be guided so we can do the better for these patients. And with this, I will finish. Thank you.
Thank you very much, Professor Pinto. So